Welcome to the Munch podcast. I am Megan Vanoy, orofacial myofunctional therapist, along with my good friend Kimi Nishimoto. All right, you guys, we're super excited. We have Dr. David Shirazi on with us tonight. I guess actually depends on your time zone if it's tonight or not, but it's tonight for all of us. So he is going to be talking with us today about cranial facial pain and TMJ, and really taking the expertise on this, you guys. So one of the cool things, that we like to do and that we're always talking about is this idea of collaboration. As much as Kimi and I like to think we can solve everyone's problems, we always work better in teams. And collaborating with experts like Dr. Shirazi is going to be just amazing, and working, collaboration over competition. That's what we say until we're blue in the face. So, Dr. Shirazi, please tell us more about you. Tell us about what you do, and then we're going to bombard you with questions.
I hope you do. Well, thank you both for having me on your show. It's such a cool show you guys have, and I love the work that you're doing. Really great.
Thank you.
So as I said earlier, I'm a dentist. I'm an acupuncturist. I was a sleep technologist for 5 years. I have a sleep lab where we do research, and my practice is limited to treating TMJ disorders, snoring and sleep apnea, and functional orthodontics in adults and children.
Where are you located, cool. Dr. Shirazi?
In the LA area. I have 2 offices, one in Brentwood, one in Thousand Oaks.
Awesome. Cool. Perfect. Excellent. So tell us a little bit more. So your background's in dentistry. So you went to dental school. You're like, I'm going to go, fix some teeth, but then all of a sudden you get into it, right? And you're like, man, there's so much more happening here. Like, what got you down to the rabbit hole?
Oh my God, you are so right. You are so right that's exactly what happened. I went to dental school wanting to be an oral surgeon. And I was very lucky. I was in a group of 5 on their cadaver. I brought my own scalpel because I was a dental assistant for 8 years before dental school. So I assisted perio surgery. So I was I love surgery. So I had my own scalpel, and I did most of the dissections. And
did your scalpel have a nickname?
No, it was just a straight number 15. And because they gave us these big honking ones, right? And I just wanted a more detail. Anyway, all of our teachers are PhD anatomists, and they would show us the what the x-rays would look like. Back then it was plain film, like lateral ceph, of these post TMJ surgery patients with all these bolts in them. And I would say, how does the patient function with all these bolts, with having everything cinched down in these jaw positions? And they're like, we don't know. I said, okay, does someone know? And he's like, well, there's very little research on it, and they're just kind of cavalier about it. And I said, okay. So I actually was very naive. I thought, well, I can't be an oral surgeon and turn down surgery, right? That's like, I used to joke to my classmates and say, well, I can't be an endodontist and say, I don't want to do those root canals, they're too hard, right? But the truth is they do that all the time. But what they say is, oh yeah, that tooth is not savable, pull it, But, and the truth is most oral surgeons don't touch TMJ. They just do implants and wisdom teeth, and they're having biopsies, and they're happy with that. And so when I finished dental school, I immediately got into orthodontics. My mom's a dentist, and she obviously inspired me to be a dentist. So she was just like, she wanted me to be an ortho from the beginning, right? Just because she thought they had like the best lifestyle and made the most money. Like that was her, like she didn't care about happiness and fulfillment. She was just more practical. And I said, well, I was taking, immediately after dental school, I started the master's in Chinese medicine. And I was doing about 200 hours of continuing ed a year. And, I was loving it because this is all the stuff you don't get in dental school, right? We didn't do rotary endo in dental school, So it was like, this is like so much better, So then I started to take orthodontic courses, functional orthodontic courses, and I was really loving it. I was really enjoying it. And then I graduated in 2001, I heard of what's called the A.L.F appliance. It's like a removable wire that's 0.25 in thickness usually. And it's, it's the first myofunctional appliance actually. It looks like a crozat, but it has an omega loop in the middle right on the spot
Yeah.
to promote the swallow, right? So, the inventor was Dr. Derek Nordstrom. He's, my mentor. And, it was shocking how many things you can accomplish with this wire. And it was like in the world of computing. So you have like Windows that like crashes and burns like, half the time. And then you've got, Apple iOS, operating system. And that one works for the most part. It's pretty good, but it's pretty regimental. You can only do so many things with it. And then there's like the Linux unit, which is like, it's just free for all. And it's like flawless, it's only as good as the person using it. Right. So it's one of those things where you can design it any which way you want. You can look at the patient and go, well, this is more of a skeletal problem rather than a dental. So I'm going to use a different anchorage point that I would use on a dentally prominent person, for example. And just watching miracles happen. Like my first case, and this is my first orthodontic case. And if you ask an orthodontist, first of all, they all thought I was crazy for taking this on as a first case, but it's one of the hardest cases for orthodontists. And most of the time they refer them out to surgery. But this was a 15 or 16-year-old boy who had, he was class 3 with anterior open bite. Yeah.
And what is that for the peanut gallery? Because a lot of our patients are not
class
dental.
3. So class 3 is when it's kind of you got that underbite where the lower jaw is forward, like a pit bull, and he all of his premolars like that, and all of his premolars already had root resorption, but he didn't have orthodontics. He was just born that way. So at the time I was doing, palatal expanders, and to be fair, most class 3 patients are not real class 3s. They're more mid-face deficiency than they are mandibular excess. The vast majority are that way, probably 90%. So that's what he was. And I expanded him, and I got him from being class 3 to being edge to edge, right? And I couldn't get him anymore. And I was very frustrated because I thought, well, I made this promise to this kid that he wouldn't have to have surgery. And, I've reached his genetic limit. And then I showed his case to my study group, and they're like, oh, just put an A.L.F on him. I'm like, really? They go, yeah. So I get the A.L.F back, and it's this little teeny flimsy wire, because I had a 4-way sag. This thing weighed like a pound. Okay. And then I got this little, and you're not supposed to activate the A.L.F on delivery. You're supposed to let the body get into a synchrony with it. And I just looked at it, and I just started massively expanding it, put it in the kid's mouth. He comes back a month later, and he looks like Julia Roberts with his smile.
Dang. Give me some A.L.F.
I couldn't, that was it. My first case, I was sold. There was nothing more I needed. And then I just kind of dove down that rabbit hole. And it was very challenging and exciting. And Derek is one of the nicest human beings that are on this planet. And I'm not just saying that because he's my mentor. He's a left brain genius, but a medical intuitive. And it doesn't have a mean bone in his body. Not one. And I asked his wife, Ruth, have you ever seen Derek mad? And she said, one time. I said, really? What did it? She goes, oh, my son, hurt his ankle, and they're at the emergency. And there's this doctor, and he goes, does this hurt here? Does this hurt right here? The kid was like jumping.
Yes, obviously.
Right. And she's like, he was going to come out of his skin. But that's Papa Bear. That's normal. It's beyond normal. Right. So, but the challenging part about Derek back then, this is over 20 years ago, was it was very hard to learn from him because he's on such a level. He's on such a different level. And for him, getting the logical left brain stuff and the ethereal intuitive stuff just go together. So he'll talk about, okay, and then you'll do, start with A, and then you'll add B, and then you'll get to Van Gogh's portrait, and then you'll get to the V8 motor in a Mustang, and then you'll get to a souffle, and then you'll get to Z. Like, and you're just like, okay. And then and you had to just follow him around because he would say things very nonchalantly, like, oh yeah, the spoons go in the spoon drawer, like something like that. But he would say it in the context of talking about the ALF, and we're like, this is critical information. We need this information. No wonder it's been so time. And that's how learning went in the beginning, right?
Yeah.
But it was extremely satisfying because one, you're promoting the use of the tongue, you're activating the lips. The appliance itself takes up no oral volume, like nothing, right? So it's not going to get in the way of what you guys are doing. And it's just great because if someone's got craniofacial deformity of some kind, like with a cant in their maxilla, it can help correct the cant too.
Hey,
right?
Dr. Shirazi.
Yeah. Yes.
For our listeners, because we get asked about ALF a lot.
Oh, good.
Do you have a little model?
Oh, show you ALF? Would you like me to run and get you some?
Yes, please.
I'd be delighted. I've got a whole bunch.
We'll talk while you're doing that.
Yeah, we'll let you do it.
Meg, tell us all about ALF.
So with the ALF, it stands for Advanced Light Wire Function, I believe. We'll have to ask him. But what is it's exactly what he was saying is really cool about it. It has that little loop right on the spot, and it uses that lightweight pressure for the body to kind of mold and meld, and it's really cool to have an expert on talking about it. So perfect. Yay, he grabbed those for us so we can take a look here.
All right, you ready for me?
He's got all the toys for us. Yeah. So he's got all the toys. He's ready.
We call this a basic ALF. Let me see there.
Yeah, perfect.
Can you see that little wire?
Yeah, it's so little. It's amazing.
So little. So you really can't see it when you smile. Here, let me turn off the lights.
It's wild that it's so small and it can still expand. That's what's so cool about it. And like he was saying, it doesn't take up tongue space, so the tongue can still rest up. That's why it's a great marriage between myofunctional
There we go. That's
therapy.
a good vintage. There you go. And then like when you see it, you can't you can hardly see it there. This is mine when I first started. Right there. Yeah. And you understand these loops that you see here, those are what we activate. Like the main one in the middle, the omega loop, where we right on the spot. And then we've got other ones on the sides where we need to get more sagittal development. And then we have different modifications. There we go.
Yeah, that's just, it's so cool. And there's such little.
Yeah, they don't take much oral volume at all. And then sometimes if someone has, like, let's say a TMJ problem where we actually need to decompress the joint, we can combine the ALF with like a TMJ appliance, right? Where we actually give some vertical, control the parafunction and still have the ability to adjust the ALF.
So that would be like the splint therapy that a lot of people will do.
Well, splint therapy goes in many, many different directions, right? Flat splint, they have these people that do myofunction, what do they call it? Not myofunctional, neuromuscular splints. And I don't subscribe to either of those two, right? The flat splint has shown, research-wise, has shown to be no different than doing nothing at all. Like it has the same success rate as doing nothing at all. it's not being effective, right?
And is that the same as a like night guard from your dentist?
Yeah, that's essentially a night guard. Some night guards are not considered flat. They're what's called a centric relation appliance, which is the exact opposite of what you want. So for example, if you have, these are two uppers, but imagine one's as the lower, right? So when a dentist makes a centric relation type night guard, centric relation, just so you know, the definition of centric relation is when you have a bone, a joint, and a bone that are like lined up properly. Okay. That is how orthopedic surgeons, chiropractors, and physical therapists define centric relation. Okay. In dentistry, we have 25 definitions of centric relation. Okay.
So really super easy.
Right. And I mean, let's just be honest, most of them are wrong. Okay. And the one that's used the most is that the condyles should be seated up and back into the temporal fossa, right? So usually the way those night guards are made is the assistant does all the work. They take the impressions and then they send it off to the lab, right? No bite registration is taken. So then what they do, the lab looks at these teeth that like normally fit like this, and they're like, well, I mean, that looks like about right, like that jaw backwards, you know? And then they'll just make a design so that there's height, but you're actually retruding the mandible, right? Which is like the worst thing you can do.
And why is that, Dr. Shirazi?
So the jaw joint itself doesn't have a lot of nerves. It's not really problematic. Having a click is not the end of the world, right? But there is a huge plexus of nerves and blood supplies behind the condyle. So the more you bring your jaw back, the more you obviously compromise the airway, and therefore you also make yourself clench harder. But you start impinging on those nerves and blood vessels. Yeah. And then we get into the tension type headache. And then if it goes on long enough, we get the migraine type headache, we get the neuralgias, we get the ear pathology, because then you're compressing all that tissue up against the ear. And then if the joint is displaced anteriorly, there's a ligament called the anterior medial ligament that attaches to the malleus of the ear. So when you have a disc displacement and you're pulling on that ligament, you can cause ringing and tinnitus in your ear, right? So it's not the direction you want to go the majority of the time.
Thank you for explaining that, because I've had patients in the dental office that have been in splints for like 10, 15 years. They just live in it 24/7. It's
sad. It's sad. It's like, we have this joke in dentistry, in my profession, that specialty. The acronym WNL stands for within normal limits. So for TMJ patients, it stands for we never looked. Right? They just never looked.
So I'm pulling up my screen here so that way people can kind of see what he was just talking about. Right? So obviously you're the expert here, but ear canal, we've got the lower jawbone, right? This is the condyle area he was talking about. And that's the nerves are right up in here in that disc space, right?
Posterior to the disc space, yeah.
Back in here. Is that a pretty good visual for you?
It's decent. I think it's decent. Yeah, it doesn't need to be more detailed.
Simplified. Yeah. So people will complain, about like their jaw joint hurting. A lot of times they're talking about kind of right in here, or even kind of right in front of the ear and into that area. So that's when, you get prescribed the night guard for the clenching and grinding. I always say patients make it seem more like it's a chew toy and make things worse and make things better. And they're like, yeah, actually it really is like a chew toy. And, so how did you, you started getting to the A.L.F. And now remind us, what does A.L.F. stand for? Advanced Light Wire.
Functional, yes.
Nailed it, Megan.
Yes, you got it.
Functional. You had it right.
Oh, I had it right the first time. Okay. Perfect. I was like, I'm just going to throw in words and see what happens. No. So how did then you kind of transition over to the TMJ, the cranial facial pain?
Oh, okay.
How'd
Yeah.
you end up there?
I will tell you, there is an actual breadcrumb trail.
Sequence.
But I want to talk about just for a moment about what you said about them using it as a chew toy, the night guard as a chew toy. This is a fact. Okay. So we now know, it's pretty well documented, that about half the time, the reason why we brux is because of some form of sleep apnea, usually upper airway resistance syndrome. Yeah. So
Agreed.
so once we have that knowledge, then what they did was, they've done 2 studies that I know of. They took patients, one was out of, I believe, Toronto Dental School. They took patients that had sleep apnea, but couldn't tolerate their CPAP. They gave them night guards, and they said, well, let's do a follow-up sleep study with just your night guard, right? And 50% of them, their apnea got way worse. And therefore, guess what? They clenched harder. So so that's why it becomes a chew toy. I just wanted to point that out. So I was studying the functional ortho. I was taking Derek's stuff, and the parents would come in and say, well, thanks for helping out my kid. Can you work on my TMJ? And I was like, sure. So then I'd make them an appliance or 2, and they would come back and say, my migraines are gone. I said, well, good for you. I didn't even know you had migraines. They said, no. When I take your appliance out, my migraines come back. I thought that was, I didn't even tell anybody. I just said, whatever. And then like 2 months later, the exact same thing happened. So then I went to my study group and I was like, have you seen this before? And basically the consensus among all the doctors was 75% of headaches and migraines come from the jaw. And I was so shocked by this. I said, no. I said, if this was true, I would have known, I would have known this, right? But I kept saying, and then of course, then you go and do a PubMed search, and then you start to see that there is a lot of studies on the subject, right? Not just a constant correlation, but like a resolution of headaches and a reduction in migraines with an oral appliance. Now, when it comes to migraines and oral appliances, we don't have like robust studies, like a double-blind, placebo-controlled, et cetera, which is harder to do with an appliance. But there's no funding for these kinds of things. The studies are done, small studies out of dental schools, and the vast majority of dental schools are still doing flat plane splints. So that's why you're not seeing good studies out of them. But you're seeing either individuals, doctors that are taking the money out of their own wallet to do the study for the greater good, or they're publishing like a case study or 2, like 1 patient, 5 patient, 10 patients, and just showing their data. And you'll see this in like the oral facial pain crowd will complain that there aren't like the robust studies like they have for all the drugs that they prescribe. And it's like, well, because there's no financial gain, right? There is no patent on an appliance. There is no secret chemical in there that someone has to pay money for, right? It's just a piece of plastic holding the teeth and the jaw in a certain jaw position to control parafunction. Yeah. So it's not, there's not going to be a lot of money thrown at it.
Now, for our patients that aren't aware, what is cranial facial pain in very simple terms?
So it loosely refers to pain of the head and neck, right? Which includes the face, of course, right? So the cranium is what sits, on our neck, and the base of our cranium is the maxilla, right?
Or our upper jawbone.
Upper jawbone, thank you. And our mandible is more loosely attached, but behind the mandible is just such a huge plexus of nerves that it has a profound effect on everything that we do in our body. So, for example, in bringing it back to migraines, there is a phenomenon called central sensitization, okay? And what that is when you have pain that's gone on for so long that it starts to make other parts of the body hurt or have a problem that have nothing wrong with them. Okay. So normally we call, if it's acute pain that's hurting somewhere else, we call it referred pain, right? You have like a subluxation in your neck and you have hand or finger pain, right? Referred pain. Central sensitization is when you have the neck pain for a very long time. It's not addressed. The hand pain is not addressed because it's coming from that. And then it creates plastic changes to the brain itself via the trigeminal ganglion and starts making other parts of the body hurt that have nothing wrong with them.
Is that similar to like fibromyalgia, or is that a part of that
Well,
phenomenon?
yes, it is. So fibromyalgia is centrally mediated. Yes. So it's not like, they have all these palpation markers, for people with fibro, but it's centrally mediated. There's nothing wrong with their arms and legs, but it's like that. So like, people call a migraine a trigeminal vascular disorder because the blood vessels open up and close, right? But the blood vessels don't, function on their own. Like a nerve has to tell them to contract or dilate, right? And we see a strong, it's not all of them, of course, but we see a strong overlap on patients that have migraines that also have a TMJ disorder. And we see resolution of these migraines on patients that get their TMJ problem successfully treated. Even on patients that have menstrual migraines. These are the kind of migraines you get right before your period, right? Which is interesting because you think, okay, well, that's
so many patients will say, well, no, my migraines are just hormone related.
Yeah,
No, they're
and they
just
are
related
hormonal.
to my cycle. Like this has nothing to do with anything else.
Well, they are related to their cycle.
Yeah.
But essentially, remember, like if you can think of central sensitization as you got this bucket and pain is being given to it. And if pain gets to a big enough threshold, the bucket overflows and causes some other problem, right? So if your bucket is filling up with, a terrible estrogen progesterone ratio and a TMJ problem, well, even though you haven't done anything to the estrogen progesterone ratio, if you did something to stop the impetus of pain from the jaw, for example, the bucket is not going to be so filled up that it overflows. Does that make sense?
Okay.
That makes sense?
Yeah.
Is that too complex? Kimmy, are you there?
I'm here.
Does it make sense?
Yeah. I actually have had several patients who had really severe migraines or headache issues. And with myofunctional therapy and getting their tongue tie released, they had such reduced tension and reduced clenching that their headaches really significantly minimized. Or one girl, they were actually gone, which was really good. Wonderful. And then the next step for her was going to be expansion. But to get her not clenching her teeth and get her tongue up and then breathing better, it made a huge difference. So for our listeners, where are the most common TMJ headaches? Like, and show us with your hands.
So tension type headaches are the most common TMJ associated headaches. And those, it's kind of like a vice grip, front and back. Sometimes they'll feel the muscles tensing on the side, on the temporal bone side. Those are much more dull. They're like not 10 out of 10 headaches. They're like between a 4 and an 8, right? And they're just sort of like tight. Makes it hard to think, they're very challenging. Whereas a migraine is something, it's almost debilitating. Like one of the best ways of correcting it naturally is to just take a nap. Just close your eyes, get out of the light and go to sleep.
Yeah.
And it's often associated with overwhelm.
Okay. Yeah. Yeah. My headaches were always in the occipital area. That was my favorite place to have headaches.
There it is. So, so what tension type headaches are? They are compression against C2 and the occipital bone against the greater auricular and greater occipital nerves. That's what tension type headaches are.
So the base of the skull, where it connects
base of
to
the
the
skull.
neck.
So the vertebra and the base of the skull are squeezing at that nerve, and that nerve radiates from back to front. Yeah. And that's why they'll feel it here and they'll feel it back there. And that's why a lot of them will go to a chiropractor and they'll adjust their neck and they immediately feel better. Like instantly the headache's gone, right? But then they'll go home and clench their teeth and then comes back.
Yeah. So what's, I guess, and this is like, could be like a huge can of worms, but like there can be multiple. So what's the solution, right? So what's the solution for the clenching? What's the solution, finding the right TMJ doc who actually, can help towards this direction, versus again, just doing like a flat splint or, just going to chiropractor, but then we go home and we clench some more and we come back and get caught in the cycle.
That's right. So excellent question. So I have 2 offices, but mine are just 2 of, I think, over 65 centers.
Oh, wow.
Where we have the same methodology and the same testing parameters and the same mindset of how to achieve. We've all been trained by Dr. Steve Olmos. And we have all over the United States, all over Canada, all over Australia, New Zealand, England, Bahrain, Dubai. We're pretty ubiquitous. So there is a website, tmjtherapycenter.com, and center is spelled the British way, CENTRE, Centra, as I like to say, tmjtherapycentra.com. And then you can click
Very
on,
fancy.
right? It sounds fancy. I think it was
Very fancy.
I think it was because someone already took the American way. And it turned out to be excellent because we got Canada and Australia and England, and we have more centers using the European way.
I love
anyway,
it.
if you go on the top right, they have like our centers of excellence, and there's a global map, and you can put in your address and find someone near you.
So cool. That's so cool.
I wanted to ask you a question. So ALF, for our listeners, is actually, unfortunately, really uncommon to find a provider.
Very rare. Very rare.
It's hard.
But
yeah.
Where could someone go online to try to find someone who's an ALF provider?
I'm gonna have to send you the link because it's kind of like a little bit complex.
We can share that in our.
I'm more than happy to share that with you. Yeah.
We'll put the link in the description box then.
I think there's only, if I had to hazard a guess, I would say there's only about 1,000 of us in the world. There aren't too many of us.
In Colorado, where I'm at,
isn't that crazy?
In Colorado, I think there's 2.
I believe it.
Yeah.
Well, there is the lab, the very first lab to make a ALF was in Grand Junction, Colorado, named Murdoch.
Nice.
Yeah. And Dwight Murdoch was just the greatest. Like he was very chatty.
Colorado.
Yeah. Right. Colorado's gorgeous. Come on.
Oh, love Colorado.
Oh, yeah. Oh, it's beautiful. And the people are sweet.
They're okay.
I think overall they're good. If I ever called him with a question about how to design an ALF, because he's a lot easier to get a hold of than Derek, we would talk for a minimum of a half an hour. Like there was no way I was getting out of a conversation with Dwight. And I learned so much from those conversations and from him. But the very first center, the very first place to make an ALF outside of Derek's hands was Murdoch Labs.
Nice.
That's awesome. Yeah. It's so interesting. And what's so hard is it's like it's hard to find. Patients have to go down all of these rabbit holes. They've spent tens of thousands of dollars on this splint, on that, sleep apnea appliance, on this. And it's like, by the time sometimes they get to us as myofunctional therapists, they're exhausted mentally, emotionally, financially. And, it's hard to almost undo kind of what's been done. So knowing that there's some really great options out there that they can even start with, I think is going to be a huge deal. Like knowing they're going to the right mindset, the right group. One thing we talk about with patients a lot, and kind of at the beginning of any of my consultations, is like, hey, we don't work on the structure. We work on the function to support the structure. So you have we're going to have to pair up and collaborate with that structural person so we can really get you to where we want to be.
Mm-hmm.
And
Yeah,
so having those
that's brilliant.
resources.
So one thing I wanted to talk about here is some of these people, they get trapped in the, oh, just night guard, or here's a splint therapy, you're going to wear this appliance 24/7 for the rest of your life. So when is it a good idea to maybe see someone who can address the structure and change the bite and the bone structure? Because sometimes that is the anatomical root of their problem.
That's right. That's right. So, so my training was in this, craniofacial approach from Derek, as well as this whole TMJ and sleep mindset of understanding parafunction, the importance of sleep, the importance of nasal patency, the importance of swallow. So we have all the centers do what's called motor reflex testing. It's a neurological evaluation to find out not only what is in central sensitization, but what's the hierarchy? What do you treat first, second, and third? Because sometimes a jaw problem could, right? It's very rare. So sometimes the jaw problem might be a reflection of what's going on in the SI joint. Might be a problem with nasal breathing, might be a problem with the neck. And just the clenching is sort of like the salt on the top, right? And sometimes their jaw problem is what's causing their neck problem and their back problem and their headache and etc. And we need to treat that as a primary, right? So, and then sometimes the patients don't test for any TMJ problem at all. They don't test for any other outside of the cranium, what we call peripheral nerve problem. Well, we take a look at them in our CT and we can see that they're, they have this cant problem and this cranial distortion and their face is compressed. And, unfortunately, many of them have had 4 bicuspid extraction when they were younger. And those patients need some kind of more cranial facial, more bony changes in order to get where they need to be.
And how would someone go about that? Is that like the A.L.F for expansion,
The A.L.F,
orthodontic?
Yeah, the A.L.F. I mean, obviously that I'm biased. I mean, I think the A.L.F is the greatest thing, ever in orthodontics.
That's okay. You can be biased.
Being honest, right?
We'll let you.
But like, there's tiers, right? Whereas if A.L.F is the best, then we have this group called Functional Orthodontics, where we're doing expansion, and even the BioBlock appliances by John Mew, they also promote keeping the jaw in the right place and expansion. They just really manhandle the tongue. That's kind of like the issue. But if your choice was that or conventional orthodontics, there's no comparison. Right. So we have, like, let's say A.L.F style functional orthodontics, and there's a form of brackets and wires called passive self-ligation. Okay. And then you have conventional ortho, right? So it's conventional ortho that I have no filter. So I have a very hard time finding a political nice way of saying it. So conventional orthodontics is lazy orthodontics.
I agree.
Someone didn't want to take the extra step to learn a different way of making the teeth fit in the arch. Right? Whether it's because you can put springs on these wires and create room for all these patients. You can, even if you've got someone with a little bit of a class 3 profile again, they actually have anchors. You can actually put like these temporary anchorage devices and kind of pull all the teeth back. All right. It's amazing. There's so many things you can do without pulling teeth, without sending the patient for orthodontic surgery. Those should be like the last option. And I'm not saying I've never recommended bicuspid extraction, right? Like if someone has like that bimax protrusion where their upper and lower teeth are really forward, when it's not ethnically normal, or if it is ethnically normal and they don't want to look that way, they don't want to look ethnic, right? Those are some indications for doing bicuspid extraction to kind of bring it all back, right? Which is a better alternative than having orthodontic surgery, right? So, I mean, there is a time and a place, but it's very few and far between.
Versus conventional ortho, it's like,
yeah,
take
it's
these
not
out, take
1
these
in
out.
5. It's not even 1 in 10. It's a very small percentage of people that need healthy teeth amputated in order to make them all fit in the arch.
Right. Because then where's the tongue going to go? Right in the airway. And then here we are.
Yeah. And then I don't know if you guys know this, but the American Academy of Orthodontics did their white paper on airway and orthodontics. Did you read this?
Tell us. Tell us about it.
Oh, well, it was frankly embarrassing. It was frankly embarrassing. It, you know, at first when I heard that they did it, because white paper means we're starting with a blank slate, right? This is new, unconventional. We're like, well, great. This is exactly what the industry needed, right? And they set about doing everything wrong using their old thinking. It's unbelievable. I can't even imagine they did this. So they talked about airway. Then they talked about a small airway, let's say on a CT scan, right? And how that can, you know, be indicative of sleep apnea. And it's like, well, no, you diagnose sleep apnea from a sleep study, right? A static picture of someone wide awake and sitting up is no indication of sleep apnea. It's an indication of a small airway, right? So a small, you know, sleep apnea is a neuromuscular disorder. So you need a sleep study. There's no other way out of that. So then they went to, now orthodontics usually feel like they are like the top of the pyramid, right? But there's only one group that they kneel before, and that's the oral surgeons. Yeah. And so they said, this is unbelievable. They said what's called MMA surgery, maxillomandibular advancement surgery. That's where they break the jaws, bring them forward, and bolt them down. Right. And they said that is an excellent treatment for people with sleep apnea. Right. And it is definitely an option. It is an option that works. Right. And they said, by bringing everything forward, it improves and increases the airway. They can even see it on an x-ray, right? And then in the same breath, they said, for bicuspid extraction with retraction mechanics does nothing to the airway.
Tell that to me, man.
Right. So I don't know if it's willful ignorance or if it's cover your butt or what, but it's certainly not based in logic and sense.
No.
Right.
Yeah.
So we've been waiting for them to come around, and I hate to say it, but it's like the only way that things will change is if enough of them, you know, retire or drop dead. I don't know of it in any other way, you know.
Or a lobotomy.
That's a harsh.
I don't think lobotomy will help. I don't think a lobotomy will help. They'll find a way of making it happen after the lobotomy.
It's a harsh way to end the podcast.
Sorry. By the way, if you want a fun tidbit, the guy that invented the lobotomy procedure won the Nobel Prize.
Oh yeah.
There you go. Well, it's been so fun to have you, Dr. Shirazi. Thank you so much. Like, we are always getting questions about appliances and trying to figure NTMJ pain and night guards, and, you know, so much of like the mainstream stuff people really see out there recommended, and trying to figure out kind of what to do, where to go. So I feel like you gave us so many good, awesome resources to really, you know, hand off to our listeners and to our patients. So thank you so much for sharing with us tonight.
Oh, yes, it's my sincere pleasure. If you'd like me back, I've been lecturing for over 15 years. If you want me to put an ALF presentation together for your audience, I'd be delighted.
Yeah, that would be kind of
cool.
That'd
be awesome. We'd
to
love
have
that.
some before and afters or something.
Sure.
That would be really cool, actually.
Yeah, that would be.
Mini special.
I think you'll like
email and
it.
plan for that.
Okay. Well, great.
Perfect. So if patients wanted to, you know, find you, we know that the TMJ Therapy
Centra.com, right? So the fastest way would be going to tmjla.com, right? I have
Okay,
two offices.
perfect.
The other office is tmjconejo.com, but they both go to the same
Okay,
website.
perfect. Okay,
And
perfect.
so you'll find me there.
That's
Awesome.
awesome.
Wow.
Great. Perfect. Well, we'll email you about the ALF presentation to learn more, but
Okay.
we'll let you get going for the night. Thank
Okay.
you so much for being with us. And sounds like we're going to be back for round 2. This is how we reel people in. We bring them back.
All right, good. Beautiful. Thank you guys for
Bye.
having me. Bye.